Okay, now let's start and have a look at testicular pathology. Where should we start first? I think this will be fine. So these are the seminiferous tubules. Can you identify the germ cells as they mature? Can you tell me? Which are the ones that are very close to the basement membrane? These are the more immature cells. They are, name, spermatogonia. All right? So let's try and find another one when we have the levels of maturation more distinct, because here they are mixed. It's not a good tubule to study. So where shall we try? Let's have a look here. I think it's better. So this is the basement membrane. In the interstitium, what are these cells? In the testicular interstitial tissue, these are Leydig cells. All right. They produce testosterone, having to do with the secondary characteristics of the male gender. Now, here we have spermatogonia. These are spermatocytes, two classes, A and B, and these are the spermatids, more mature forms. The immature spermatids are with round nuclei. The more mature are elongated. So if we find elongated spermatids like this one, we can say that the maturation is full. Because which cell do they look like? The elongated, the mature spermatids, they look like sperm cells. So it's not, we do not always identify sperm cells in the tubules because they live with the sperm. But when we see these elongated cells, we can say that the process of germ cell maturation, the process of spermatogenesis, is active. Now, let's have a look at a different tubule. Now, what do we see here? What are all these cells? Do you remember from histology, apart from germ cells, what other cells are there in the seminiferous tubule? And they somehow support the maturing germ cells. What other cells are they? Sertoli cells. So these are Sertoli cells. They have all these, you see that the cytoplasm is not so well defined, you see? And a basic characteristic is this nucleolus in the Sertoli cells nuclei. So are there any germ cells in this tubule? No. So this is an aplasia of germ cells. That means that the only cells we can identify are non-germ cells, are Sertoli cells. Yes. This is a pattern of damage. Now let's have a look here. So now, this one, this tubule, apart from Sertoli cells, can you identify the Sertoli cells? Look at the nucleoli within the nuclei. Are there any other cells that we can identify as germ cells? Yes, there are. These cells close to the basement membrane. You remember how we called these cells close to the basement membrane? These are spermatogonia. Spermatogonia. So there are some germ cells in this tubule, however, they do not mature. And this is an early arrest in the spermatogenesis, because we see germ cells. This is not a Sertoli cell only syndrome, because we can identify germ cells, but they are immature cells, spermatogonia. So there are two forms of spermatocytic arrest. The one that we see germ cells of early stages, and the other is spermatocytic arrest of a late stage, where we can identify spermatogonia, spermatocytes, and only immature round spermatids. All right? This is late stage spermatocytic arrest. Why? Because if we are able to identify elongated, mature spermatids, this is not aplasia. This is complete spermatogenesis, as we have already stated. So this is the other pattern of injury and of having to do with infertility. And there is also another one which has to do with presence of mature spermatids, but thinning of all layers of germ cell. So if you are able to identify mature spermatids, but the layers of the remaining germ cells are thinned, and there is a reduction in the number of germ cells, this is called hypospermatogenesis. So what are the patterns of infertility? Sertoli cell syndrome only, early spermatocytic arrest, late spermatocytic arrest, spermatogenesis, hypospermatogenesis, and active spermatogenesis. Rarely does one of these patterns is the only one that you can see. Most often they coexist in various percentages. So what we have to do? We count all the seminiferous tubules and we say in 10% we can see active spermatogenesis, in 5% hypospermatogenesis, and so on. This is our everyday handling of such specimens. For example, let's check what we can see in another testicular biopsy. Have a look here. This is an exception that we have one pattern only, one pattern of infertility throughout the tissues. Which cells are identifiable, and these are the only identifiable cells in such tubules? Can you recognize the cell type? Let me make a magnification. Oh, yes. What do you think? What are these cells? Remember, with their nucleoli? Sertoli cells. So, since this pattern is the only one observed throughout the tissue specimens, then we can put it in the conclusion of the report, and we'll say this is Sertoli cell only syndrome. It's not so wise to try and find the cause. We just report what we see, because this has to do with the patient's history. For example, we have to know the hormones, hypophysis hormones, FSH, LH, testosterone, thyroid hormones, because in many cases of hypothyroidism, there are changes in the sperm. And also, sometimes we have to examine to know the result of the karyotype for genetic syndromes and the patient's history, because if the patient receives high doses of chemotherapy, and as we know, chemotherapy targets cells that divide actively, like the hair follicles, and we lose the hair when we have chemotherapy, or the cells of the gastric mucosa, which renew all the time. So we have vomiting as a side effect of chemotherapy. We can have a Sertoli cell syndrome only due to chemotherapeutic toxicity against the germ cells. So now we'll have a look at the basic germ cell tumors of the adult. Now, have a look at one category of such tumors. Now we are talking for adult patients. You see, here are the seminiferous tubules. I see the basement membranes are thickened. This is probably a sign of atrophy. And we have all this dense fibrous tissue. However, there are some tumor cells which have clear cytoplasm and a lot of lymphocytes around them as an evidence of immune response of the host. And these lymphocytes are located in these septa. This is one type of germ cell tumors, and if we have pus stain, we'll find glycogen in the cytoplasm of malignant germ cells, and these are seminomatous cells. This is a seminoma, which is one category that can be detected on its own. What do I mean? Most often, germ cell tumors of the testis in the adult are mixed. They can be seminomatous and non-seminomatous, or non-seminomatous of various types, as we can see. However, there is a tumor that can be detected on its own, and this is seminoma. As far as non-seminomatous tumors are concerned, they most often are found mixed in various portions. So let's have a look at the non-seminomatous tumors, but before that, I'd like you to understand what is all this tissue, the scar tissue, that has replaced a large amount of seminomatous cells. This is called regression. What is regression? It is a process that either the whole amount of the tumor or a part of it, in this case a large part of the tumor, is replaced by fibrous tissue. The same happens in melanoma sometimes of the skin. So what's the significance if we have this partial regression? Many times it's not for good, because if we see a large amount of fibrous tissue replacing the parenchyma of the tumor, most probably the tumor has metastasized. So we have to look at the retroperitoneal lymph nodes, if they are enlarged, as well as the liver, the lungs, the central nervous system, to detect possible metastasis. So regression is rather an ominous finding when we see in the tumor. Let's have a look at the other type of tumors, the non-seminomatous ones. How? This one. Have a look. This is a tumor which consists of mature tissues. This is stratified epithelium, this is cylindrical epithelium, stroma, and here is keratin making a cyst. So it is mature and it looks benign. So this is a teratoma of the testis. However, in the testis, not the ovary, in the testis, teratoma is always malignant, because as we can see in this case, there are some malignant cells in the tumor-adjacent seminiferous tubules. What is this? This is in situ germ cell neoplasia. Any tumor that has in situ germ cell neoplasia as a precursor lesion is malignant, is always malignant. Okay? Yes, please.
How do we know that it's inside one germ cell? Because we have malignant cells outside the seminiferous tube.
No. Here, all malignant cells are within the seminiferous tubules.
Yes.
How can you tell that they are malignant and they are not spermatogonia, for example? If there is doubt, they have nuclear atypia. But if there is doubt, you have immunohistochemical markers for seminoma, because these cells are seminomatous cells. These tumors can turn to each other. A seminoma can turn into embryonic carcinoma, to yolk sac tumor. They change their phenotype. However, if you find intratubular germ cell neoplasia, in situ neoplasia of germ cell, any tumor that is nearby is, by definition, malignant, no matter how mature its elements look like. This is not the same in ovaries. In ovaries, a mature cystic teratoma is benign. An immature teratoma has malignant potential. As far as neuroepithelium is, we have the counting of the neuroepithelial elements in an immature teratoma of the ovaries. This has nothing to do with the testes. A teratoma is always malignant in the testes of the adults. It's always malignant. That's right. So, next. Other tumor. Let's have a look at this one. This is the embryonic carcinoma. It has primitive-looking cells, either in compact seeds or cribriform, and sometimes papillary structures, like here. This is an aggressive malignancy, which is characterized by, what are these cells? Why do they look like this? What are these cells? And what are these cells? This is very important to discriminate because it justifies the chemosensitivity of subtumors. Can you describe these cells that their nucleus looks like a line, an irregular line? Which phase are they in? Which phase are they in, these cells? Mitotic. Increased mitosis and increased, the other ones that they are like dust, the nuclear dust, you can see here.
They are separated. No?
Yes, this is the mitosis. The ones like these ones here, this is the mitosis, all right? These ones, you see, all these small fragments of nuclei. What is this phenomenon? What is this phenomenon? And how is it related to the chemosensitivity of the tumor? Excellent. It is apoptosis. So if you give a drug that induces apoptosis and the tumor already has increased apoptotic potential, the tumor cells kill themselves. They commit suicide, some sort. So this is the embryonic carcinoma. And the other germ cell tumor is the yolk sac tumor, which increases alpha fetoprotein in the serum of the patients. Let me show you the yolk sac elements. This is the most common pattern of yolk sac tumor, the microcystic patterns. If you have an immunohistochemical stain of alpha fetoprotein or glypican-3, you'll find it. You'll find it here. So, rarely are these tumors the only tumor. They most often coexist in the adults, and they are always malignant. For example, this could be an embryonal carcinoma coexisting with the yolk sac tumor, and this could be a teratoma. Look at these papillae with their simple epithelial lining. Okay. And it is of interest that commonly the germ cell tumors, here is the teratoma component. You see, these glands, they belong to a teratoma. Most common in these tumors, there is some sort of elevation at the levels of human chorionic gonadotropin hormone. So if such a patient has a pregnancy test, it might appear positive, because these cells are most often separate syncytiotrophoblastic cells which secrete human chorionic gonadotropin. We should pay attention and not overdiagnose the presence of single syncytiotrophoblastic cells secreting human chorionic gonadotropin up to levels of 500, 1,000 in the serum, and not overdiagnose a choriocarcinoma, which is the most aggressive tumor of them all. And this tumor requires very intensive chemotherapy. However, in choriocarcinoma, we have two cellular populations, not only syncytiotrophoblastic cells, but what other cells do they form the placenta villi? Syncytiotrophoblastic and trophoblastic. So a choriocarcinoma, as a rule, has both cell types, syncytiotrophoblastic and cytotrophoblastic, and the levels of the secreted human chorionic gonadotropin from the tumor are in the class of 50,000, 100,000, not like those which are secreted by single syncytiotrophoblastic cells dispersed throughout the tumor, which can be encountered in any type of germ cell tumor. A seminoma can have such cells. An embryonic carcinoma can have some such separate syncytiotrophoblastic cells. Yes, please.
You said not overdiagnose?
Yes, when we have such single cells, we do not diagnose choriocarcinoma because this is another tumor. In order to diagnose a choriocarcinoma, the rule is to find both syncytiotrophoblastic and cytotrophoblastic cells in a biphasic pattern resembling the villi of the placenta, the villi of the placenta. So these were the germ cell tumors of the testes, which as a rule are chemosensitive, and this is a field that oncology can give therapy to the patients and not just a prolongation of the survival period, such as in other tumors. So that was the first part of our lesson today. Embryonic carcinoma is a germ cell tumor, non-seminomatous tumor. Embryonic carcinoma. Another type of non-seminomatous germ cell tumor. We had teratoma, embryonic carcinoma, yolk sac tumor, choriocarcinoma. 4 types, main types. So